Hello, everyone. My name is Dr. Ferghal Armstrong, and welcome to this episode of Cracking Addiction. And today we have with us Dr. Matthew Frei. Hello, Matthew.
Hello, Ferghal.
So, Matthew, for the benefit of the viewers and listeners, what exactly is your specialty?
So I'm an addiction medicine specialist. I work in an alcohol and drug service in Melbourne called Turning Point. I'm the clinical director of the Eastern Treatment branch of Turning Point in Melbourne, and I've been doing that for 20 odd years or longer.
Right. And that experience, of course, allows you to, progress into what we would term as non-clinical work, wouldn't it?
Yeah, it's sort of, there's certainly a strong clinical component, and it tends to be work that's done by clinicians, but it doesn't involve the therapeutic aspect of clinician work, and it often doesn't involve actually interacting with a patient.
Yeah. But one of the things that you do is you do a lot of report writing, don't you?
I do. It's something that I find one of the things I enjoy in medicine after all this time. I like writing, and I like the process of putting out a report together. I'm not saying I do it incredibly well or they're incredibly fantastic reports, but I think anybody that enjoys what they do can make a reasonable fist of it. So, that's why I do a bit of this sort of work.
So who commissions reports from you?
It's a variety of people. It's the classic stakeholder or requester of reports tends to be your insurance companies. But there's also the regulator, the AHPRA, the regulator of the health professions. Various solicitors contact me, the coroner, often many opinions to the Victorian coroner. This is one of the interesting things. The Justice Department, the prisons people. The interesting thing is you actually do get. It's considered dull work, I think, by people, but you actually do get this incredibly broad range of people referring or asking you to write reports from a wide range of areas. It's not just insurance companies or the driving regulators or anything like that. It's much broader.
Yeah, I mean, I think it's really important to understand the breadth of referrals for reports. And, whilst we might think that driving and insurance are fairly banal, I mean, they are important issues. So, I mean, let's talk a little bit about the driving regulations. Why is it that an addiction specialist would be writing a report for driving?
Yeah, so the most common reason is that a driver or the authority regulating drivers, wants to know whether the individual can drive, basically, or how safe or otherwise they are. So it might be somebody who's, been roadside tested and come up with a positive test for the drugs that they test for or alcohol, and contesting some aspect of that, or want to show that they're in recovery from whatever drug or drug use behaviour was picked up. And sometimes they want to do that because they're commercial drivers. They want to get back to work, driving passenger vehicles, commercial vehicles, ride-share vehicles. So they're the sort of driver stuff that comes through my door.
So there are two standards, aren't there, for driving? Could you explain to us what they are?
I think you're referring to the commercial, and there's a few branches I gather of the commercial driver license, and then there's the passenger vehicle, the personal, and private.
There's the private, so private and commercial.
Passenger vehicle's the wrong term, but yeah, the private license. So, and a higher standard is held to the commercial driver, or the passenger vehicle, the person ferrying people for work for their job. So bus drivers and people driving large vehicles that can cause a huge amount of damage if not driven well.
Yeah.
Trucks.
I mean, it's understandable, isn't it? Because when you're on the roads, you have a responsibility not only to yourself but also to other road users. And yeah, so it's understandable that there have to be standards around drug impairment whilst driving. But it's not it's not true to say that if you've had an episode of being drug impaired and being caught by the police that you're never going to drive again. You know, it's there are rules that allow you to return back to the road. Would you care to explain what they are?
Well, yeah. Look, I'm not a solicitor, and but certainly people are probably aware that there's some now mandatory requirements for people testing 0.05. I believe it's alcometer and fitted to your car, so you've got to blow into this device and establish that you're not got any alcohol on board, before you can start the car. Otherwise, it locks you out.
That's called an interlock, isn't it?
That's right. Yeah, an interlock, and that's now, I gather, and again, I'm not an expert on road law and road penalties, but I gather that that's now required for anybody who gets the standard driving under the influence or over 0.05 charge, is that they've got to get one of those fitted for, I don't know for how long, but but they eventually, I understand, they eventually are able to remove that, and they no longer have to have that. That's not forever, as far as I know. And the same thing with drug use, and probably I get more of those referrals for drug use because the area is a bit grey. I believe certainly the test doesn't have the same rigour and value around it that our very well established alcometer, our breath test does. So there's a little bit of uncertainty, I think, both in the interpretation of those tests and in the actual accuracy of those tests to some extent. And it's often a question that's asked, was this prescription drugs that they were using that like they claimed, or no drugs at all? They deny being drug affected at all or using drugs, or was just a very small amount. And that's a real challenge because a lot of these tests will not necessarily be good at showing, particularly the oral swabs, at showing amount used, just that it's been used and it's tripped the threshold of the test, which is claimed to put it's claimed that the threshold is at a point where there would be expected to be impairment. But we don't have that rigour like we do with the traditional breath test.
Yeah, it's just whether or not the substance is found on the test, because it's a test of presence. Really, it's not a test of impairment, is it?
That's my understanding. I mean, there's some refinements to the test and some additional tests, like we did with urine testing, to clarify, that it is a prohibited drug, a drug that's prohibited to be in your system when you're driving. But with the alcohol test, I mean, you get a sense of how much or when the last drink was, and based on the decay of the reading and so on. But it's not quite so straightforward with cannabis and psychostimulants, which are the classic drugs they test for with their oral swab.
Yeah, and of course, if you've got a medical condition like ADHD and you're taking prescribed stimulants, well, then of course that's going to cloud the issue of whether or not you test positive.
Yes. And look, even things like some decongestants and nose and eye drops. There's a few things that can give false positives. And look, that people that have nose drops don't get lose their license. It's just a bit of if they're unlucky enough to get picked up for it, there's just a bit of clarification that's needed. But there's a few false positives, particularly with the swab, is my understanding.
Yeah. So let's move on to the insurance reports. What kind of issues come up with insurance reports?
Probably the most common insurance report these days is around pharmaceutical opioids. A lot of insurance claims, a lot of people on insurance payments for work-related injuries are on nowadays potent opioid analgesics, and there's a driver for insurance companies to minimise their outlay. That's what they're not companies that give away money, and they're often wanting to know, is this level of opioid use justified? Is it do we need to be paying for these amount of opioids, or are they escalating their opioid use for other reasons? And should we be looking at treatment of drug dependence, and therefore we'll be able to reduce their opioids, and maybe they'll get back to work as well as not consuming as many drugs. So that's the classic thing is around opioids these days, because that's that fits together with the typical work-related injury that insurance companies manage. They're the main ones.
So really what I'm hearing is that it really is focusing around the diagnosis of what is and what is not opioid use disorder.
Yep, a lot of those insurance claims around opioid use or opioids and the need for them are exactly that. Yes, is this aberrant use? Is this an opioid use disorder? Is this an aberrant condition that needs treatment, or is it just need for high doses of opioids because of persisting pain?
And that, as we both know, is notoriously difficult to work out, isn't it? That distinction between having a few too many painkillers and actual opioid use disorder is infrequently clear cut. I find that personally very challenging to make that diagnosis sometimes.
It is, and you can imagine, I think this is one of the issues that steer people away in the profession from doing this sort of work. You can imagine how tricky that is to encapsulate in a couple of paragraphs with being fair, not misleading. I believe it's still we still have to be ethical when we write these reports, and sometimes what we write is not what the person that's paying us wants to hear. But that's I think that's the beauty of doing it. As doctors, we can stick to our integrity. We can maintain our integrity when we do this sort of work because we have to. And look, sometimes they don't use a report that the solicitors and the insurance companies that's not what they want to hear or what they want to present in a hearing. But that's fine. I mean, other people I write reports for are very happy with what they've got from me. So.
And I suppose the key thing is that actually you've got to give your own independent opinion, haven't you? Because the minute you start trying to placate the person who's paying for the report, it just is a hiding to nothing, wouldn't you say?
Absolutely. I think I've done it, and I'm sure a lot of people have written these reports in the early days. We're about pleasing our customers as doctors. We want our patients to walk away happy. We want people we work for to walk away happy. And in this situation, we like the person that's paying us to write a report to be satisfied and happy with the report. Yeah. But it is a rabbit hole that you go down, and becomes really, really, really tricky. I think the easiest and the best reports are those that are based on the science, the evidence, the clinical experience, and so on. And that, I think they serve the client the best as well.
Yeah, I mean, I've written some reports, or rather, I've assessed some patients, and I've said to them, look, if you want me to write a report that's going to say that you're fit to drive again, but my report's not going to say that. And unfortunately for me, my patients have yet to pay my fees before they decide that they no longer wish my opinion. But
it's a very tough. Look, I don't envy the general practitioner that has to write a report with integrity that's truthful and that they're happy with it. They sleep at night after writing. I don't envy that for a GP where you've got to maintain a relationship with the patient. Because someone's got to ask for money at the end of the process in order to get paid and make a living. I don't know the GP should be doing these at all, frankly, because I think it's too. And you might have done them with your addiction medicine specialist hat on. But
I was referring to that role rather than my role as a GP. I don't like I don't like blurring the boundary between being the patient advocate and being an independent medical examiner. I think those two are very distinct roles, and I think as GPs shouldn't actually occupy that role. I think it should be removed from them entirely, because
absolutely. I think this is.
Sorry, go on.
This is where we got into trouble with the opioid crisis. I think to some extent it can be attributed to people wanting to give somebody what they asked for and wanting to alleviate suffering and pain. But it's a slippery slope with opioids, as we know.
So let's move on to the other group of reports that you might be asked to write, which was the reports that the coroner might request from you. I mean, that's a very sad issue, isn't it? But it's nonetheless still very important.
Yes, absolutely. And there's a lot of implication to those reports because frequently the coroner's looking at some of your colleagues or some practitioners that you may or may not know, but certainly they're looking at doctors quite often for contributing through negligence or through aberrant or inappropriate prescribing to the death of the individual that the coroner's case is focused on. So and the stories are incredibly sad, and what you've got to be cautious of is your emotional response and looking at what the doctor's done and thinking, using the old retrospectoscope, thinking that that was a really terrible thing that doctor did. And this guy's clearly a villain or clearly a fool and negligent. You've got to sort of, and it's tricky. It's hard to do. You've got to, I think, take a step back and say, well, this is what this doctor was presented with. What do you think most doctors would do? What would you do? You haven't got a crystal ball to know this is going to lead to tragedy or the death of the patient some months down the track. So what would you do in that situation? In some cases, it's still a very poor decision or negligent care that's been applied. But in many cases, it's the doctors as affected by this as family and so on. It's a very traumatic thing for everyone involved when there's an iatrogenic death.
Yeah, you have to be fair, and the retrospectoscope or the reflexive colonoscopy. It's if you've ever been on the receiving end of that, it's a very discomforting experience. I've had to give evidence in court, and you're absolutely convinced that you've done the right thing, and that really any other reasonable individual would not have formed a different opinion. And then, of course, when you have to explain your decisions in the cold light of day, it's a very, very discomforting experience.
It is. You've got family lawyers there often in the coroner's court. I was with a group of doctors giving an opinion on a very high-profile case of a death recently, and I was one of only about three of the group of about a dozen who thought the practice, one of the doctors whose practice was kind of a component in leading to the death of this individual. We thought it was a reasonable decision that the doctor made in the management. And they asked, well, why? Your colleagues don't have the same view. And I said, look, because I understand what it's like to be in this rush situation where resources and support are not there. Your best intention, your best efforts are limited by the factors beyond your control, and so in some cases I don't think that's negligent. It's not good practice, and we can own that. We can acknowledge that, but it's not necessarily very bad practice or negligent practice.
I mean, that's the thing. You're judged by the counsel of perfection, or at least you're judged against the counsel of perfection, aren't you? And the counsel of perfection thrives in a resource-rich setting, and quite frankly, most of us, I would argue, don't work in the environment as resource-rich an environment as we would like.
Correct, and it's. I think it's so easy to look back and I'm not any sort of apologist for doctors that make errors, honestly, but I think it's very easy for us to look back and point fingers. And it's a lot harder, but for family as well, I think, to say, this is there's multiple causes to this. We can't blame anyone. We can't blame the drug company. We can't blame the individual. We can't blame the doctors.
Yeah, it's a Swiss cheese effect. All the holes in the Swiss cheese have to align for the error to occur, and it's very easy to blame, the high-profile doctor or to accuse someone of negligence.
I'd much rather. I'd much rather be able to hang my hat on somebody who having caused this than be told, well, it was just bad luck. It was just unfortunate. I don't think family want to hear that.
Yeah. So therein lies the expertise of report writing, isn't it? I mean, so what advice would you give to someone who's thinking about doing a report?
Look, I think that one of the reasons I thought this was a field that I wanted to get into was also that it was at a time when our specialty was in its early days, and we were frankly struggling to get recognition by in tertiary treatment institutions, and struggling to get traineeships up and running, and consultants positions up and running in hospitals and so on. And I thought, look, we need to have in this situation, we can't afford not to be broad in our abilities and our clinical skills. And so I think it's the same thing still applies. It's good to have a few strings to your bow, so to speak. And I think I'd encourage people, to consider this as you really do learn a lot by doing these reports. They're incredibly interesting. It's really interesting work. I think most of it is much more interesting than seeing patients, in fact, because that's got its own rewards and benefits and pluses. But this stuff is very rich, a lot of this work, and I don't think I think anyone can do it who's got those skills and knowledge. You don't have to be a Pulitzer Prize-winning author or be able to write beautiful prose. You just got to be able to slog at it and be prepared to spend a bit of time early on in your reports to get them nice and clear and concise. And it's like anything, I think, writing this is practice.
So what are the pitfalls?
There's a number of pitfalls, and one of them is getting paid. It's not like there's no Medicare for these reports. They're often, and quite appropriately, a lot of money that you're billing people to do these reports. And that's another pitfall, but not that people, and I've been guilty of this, I think, undersell themselves. They charge far too little for what is you putting in not only a lot of time, but the culmination of all your skills. But one of the biggest pitfalls, I think, is that you've got to really be committed to what you're writing. You've got to understand that this is not a report that people look at and then gets filed away, never to be seen again. Some cases that'll happen, but in many cases, this it comes back to haunt you, and you want to be haunted by a friendly ghost. It comes back to haunt you when there's a court case, when there's a coroner's case, and they want you to appear. And I think there's a pitfall. These reports and these cases can go on for quite some time, and no one can predict where they're going to go. So some reports that I've done, I thought were over. I've submitted. I've been paid for them, and then several months down the track, I get this ominous subpoena, and I'm not in any trouble, but I am expected to give evidence or provide a report to the court or whatever. That's and most of us have day jobs, and it's often quite difficult to organise a court appearance and very time consuming when you've got a full-time job. So I think that's one of the pitfalls, but also about being committed and accurate and definite and honest in what you write is important. For the same reasons that it might come back later and people will pour through it. The client that you've written about will, the patient or the patient's family will look at it. So you've got to. It's not like our medical notes we might write, but they certainly get seen, but not as often as these by everybody, by the patient, by their family, and they'll pick it apart, as do the solicitors on both sides. So you've got to be careful and committed to what you're writing.
Yeah. Look, on that note, I think we've run out of time, Matthew, but I really want to thank you for your expertise on this subject, and I really hope we can speak again very shortly. Thank you.
Thank you. Thank you very much.
That's all for today from Cracking Addiction. My name is Dr. Ferghal Armstrong, and we'll see you next time.